Dipstick haematuria. Letter of referral. Dear Dr. Mr. Charles Otway, aged 43 years. This airline pilot was found to have a positive urine dipstick test for blood at an insurance medical. Repeat testing confirms this and also shows a trace of protein. He has no symptoms. His BP is 142/94 mmHg and there are no other abnormalities on examination. I would be grateful for your advice regarding diagnosis and management. Yours sincerely. Introduction. Everyone has some red blood cells in their urine. Urine dipstick tests are very sensitive and are capable of detecting concentrations of red blood cells at the upper limit of the normal range for red cell excretion. Positive urine dipstick tests for blood occur in 2.5 to 13% of men, and in most cases this is not associated with significant disease. Recognized causes of haematuria are shown in Table 1. NB. Isolated microscopic haematuria is very common. The clinical approach depends on the age of the patient. In a young person, haematuria is usually glomerular in origin, most frequently as a result of IgA nephropathy, and tumors are rare. In an elderly patient, tumors within the kidney or urinary tract are an important cause. Stones can cause haematuria at any age. NB. In older patients, older than 45 years, with haematuria, the first priority is to identify or exclude malignancy in the urinary tract. In younger patients, malignancy is very infrequent and a glomerular cause, e.g. IgA nephropathy or thin membrane disease, is more likely. History of the presenting problem. Although the patient is said to be asymptomatic, it is worth asking about the following symptoms. Have you ever seen blood in your urine, and if so, when? Blood present at the start of micturition usually comes from the urethra or prostate, that at the end of the stream from the bladder. Blood clots are unusual with glomerular bleeding. Episodes of frank haematuria, especially occurring at the same time as, or just after, a mild upper respiratory tract infection, suggest IgA nephropathy, as does frank haematuria followed by persistent microscopic haematuria. However, remember that frank haematuria also occurs with stones and tumors. Have you had any pain in the loins, abdomen, groins, or genitalia? Ask about previous pain in the loins, abdomen, groins, and external genitalia. Pain is consistent with stones or tumors, polycystic kidney disease, loin pain, haematuria syndrome, renal infection, or infarction. Painless haematuria is consistent with tumors, glomerulonephritis, interstitial nephritis, or a bleeding disorder. Other relevant history. General history. Ask about the following. Recent trauma or heavy exercise, which can cause haematuria on dipstick testing. Joint pains or skin rashes, which would suggest a multi-system disorder, e.g. systemic vasculitis. A sore throat or other recent infection, raising the possibility of a post-infective glomerulonephritis, when haematuria typically occurs 2 weeks after the sore throat, rather than at the same time. Urinary symptoms. Ask about any dysuria or increased urinary frequency, which would suggest infection. Also ask about poor urinary stream or hesitancy, or poor flow and dribbling, either of which suggest prostatic or bladder pathology. Ask the patient if he has ever passed stones, grit, or gravel in the urine. Family history. Ask if anyone in the family has had kidney problems, e.g. polycystic kidney disease or Alport's syndrome. Other important inherited causes of haematuria include sickle cell disease and sickle trait. Many patients with hemophilia or von Willebrand's disease experience microscopic or frank haematuria. Travel history. Ask if the patient has traveled to areas where schistosoma hematobium is prevalent. Infection can cause urinary tract granulomas and tumors. Drug history. Ask specifically about analgesics, which can cause papillary necrosis and therefore hematuria. However, note that this does not happen with occasional use of painkillers and has become very uncommon since phenacetin was withdrawn from compound analgesic preparations. The typical story, now rarely encountered, would be of chronic headache or back pain, with the patient consuming 10-20 or more analgesic tablets per day for many years. Plan for investigation and management. After explaining to the patient that under normal circumstances you would examine him carefully to confirm that there are no physical abnormalities apart from the raised BP, you would then plan further investigations as follows. Dipstick urinalysis and microscopy. Proteinuria combined with hematuria suggests intrinsic renal disease, especially glomerulonephritis. Interstitial nephritis is less likely. If there is dipstick proteinuria, as in this case, then quantify this by measuring the urinary albumin/creatinine ratio or protein/creatinine ratio in a spot urine sample, or with a 24-hour collection. Dysmorphic red cells on microscopy suggest glomerular bleeding, but morphological changes can occur as artifacts after collection of the sample. The distinction between dysmorphic cells, from the kidney, from non-dysmorphic cells, from the urinary drainage system, requires special expertise and is not a routine or reliable test in most centers. If seen, red blood cell casts indicate active glomerular inflammation. NB. Red cell casts indicate active glomerular inflammation. Blood tests. Check plasma urea and creatinine. Note or calculate the estimated glomerular filtration rate, eGFR, now routinely reported by many laboratories, based on sex and age. Remember that there can be a substantial fall in GFR before serum creatinine rises out of the normal range. If renal function is normal, BP is normal and there is no significant proteinuria, significant medical renal pathology is very unlikely. Imaging. Image the renal tract to exclude stones and assess renal size and anatomy. The best way of doing this is to perform both of the following. Plain radiograph, kidneys, ureter, and bladder to look for stones. Ultrasonography of the urinary tract, to measure renal size, preferably length of each kidney in centimeters, don't describe as normal or small. Look for renal masses and carefully examine the bladder wall. Other imaging approaches can be useful in some cases. Intravenous urogram to determine whether small calcific lesions are urinary stones and whether stones are causing obstruction, and CT with contrast, CT urogram, can be useful to look at the entire urinary tract for causes of hematuria. Urine cytology and cystoscopy. In an older person, e.g. older than 45 years, arrange cystoscopy to look for a tumor in the lower urinary tract. Urine cytology may be useful if there is suspicion of malignancy, but cannot be used instead of cystoscopy since it is not sufficiently sensitive to rule out a tumor. Renal biopsy. If there is hypertension, proteinuria, and impaired renal function, glomerular disease is likely and renal biopsy may be performed to make a precise diagnosis. However, note that in cases of isolated hematuria with normal renal function a renal biopsy is not recommended since it will not lead to a change in management. NB. Renal biopsy is usually indicated if there is significant proteinuria, renal impairment, or unexplained systemic symptoms. Review. See the patient in clinic with the results of the investigations and recheck renal function. Further discussion. In many cases of microscopic hematuria, no specific diagnosis will be made unless a renal biopsy is undertaken, and even then no diagnosis will be established in 50% of cases. However, the commonest recognized cause in a young, otherwise well patient is IgA nephropathy, for which there is no specific treatment. Any patient with persistent microscopic hematuria should have annual monitoring of BP and measurement of serum creatinine to enable calculation of eGFR. If this monitoring shows significant decline in renal function, then further investigation, e.g. renal biopsy, may be appropriate. It is important to consider that giving the patient a renal diagnosis may adversely affect his ability to obtain life insurance and may have implications for employment. Clearly this patient has hypertension, if the value of 142/94 mmHg is confirmed on other readings, and the fact that he has hematuria increases the argument for treating this, because strict control of BP slows the progression of renal damage in patients with renal disease. In addition, renal disease increases the risk of vascular disease and therefore the likely benefit of antihypertensive therapy.